This program will demonstrate the difference in masticatory muscle activity between the clinical and the electromyographic rest position. Determination of the clinical rest position is necessary in order to measure interocclusal or freeway space. This space is the vertical distance between the maxillary and mandibular teeth. With edentulous, partially edentulous, or full mouth restorative patients, finding the clinical rest position is the first step in reestablishing the centric occlusion position. The clinical rest position of the mandible results from an active contractile and a passive elastic component in the masticatory elevator muscles. However, they are not minimally active in this rest position. Minimal muscle activity occurs at the electromyographic rest position, where the force of gravity is equally opposed by the passive elastic component. This rest position could occur in a sleeping, upright subject who relaxes and sleeps with the jaws apart. Initially, the clinical rest position will be determined and freeway space measured. This can be accomplished in a number of different ways. On this subject, we have placed triangular pieces of adhesive tape on the nose and chin to act as reference points. The subject is first asked to close to centric occlusion with the teeth in light contact. A measurement is taken. It is 56 millimeters. The subject is now asked to wet his lips, swallow, and relax. This will place him in the clinical rest position. Another method is to have him pronounce MMM and relax. With either method, the measurement is 58 millimeters. The difference between the measurements will be the freeway space. This subject's freeway space is approximately 2 millimeters. In order to compare masticatory muscle activity to mandibular movement, the subject is connected to an electromyograph. This device measures masticatory and facial muscle electrical activity from monopolar electrodes that are placed over the body of the left and right masseter muscles. Muscle activity under the electrodes is amplified and displayed in microvolts. Next, the subject is connected to a kinesiograph. This device will show how the jaw moves in relation to the skull. This is done through a series of 5 sensors on a frame, which will be tracking a magnet placed low in the vestibule on the labial aspect of the lower central incisors. As the mandible moves and takes the magnet with it, the sensors track this movement, which is then displayed on an oscilloscope. Each vertical division on the scope is calibrated to equal 2 millimeters of vertical mandibular movement. In other words, if the scope were to show 2 divisions of movement, this would be equal to 4 millimeters of jaw opening. The use of the kinesiograph and electromyograph will display mandibular movement and the muscle electrical activity associated with that movement. This data will be plotted on a graph for examination. The subject will close to centric occlusion with the teeth in light contact. Masticatory muscle electrical activity is recorded at 5.2 microvolts. The subject will swallow and relax, returning to the clinical rest position. Electrical activity is 3.8 microvolts. He will now open to 2 millimeters. Muscle electrical activity is 3.8 microvolts. Opening to 4 millimeters, the reading is 2.8 microvolts. At 6 millimeters, the reading is again 2.8 microvolts. At 8 millimeters, 3.3 microvolts. 10 millimeters, 3.4. And at 12 millimeters, 3.5 microvolts. The muscle activity is recorded and graphed to 24 millimeters of mandibular opening. Compare the measured clinical rest position to the electromyographic rest position. Note that the jaw is opened more in the electromyographic position than at the clinical position. A second graph of another subject shows individual differences, but note that both have minimal muscle activity at an opening that is greater than the clinical rest position. This is the electromyographic rest position. Seldom, if ever, is the clinical rest position synonymous to electromyographic rest position, where the masticatory and facial muscles are minimally active. Knowledge of the role of mandibular muscles in determining interocclusal distance, as well as a clear understanding of vertical dimension and freeway space, is essential for proper diagnosis and treatment of many restorative procedures.